Hey everyone, my name is Jeffrey Pereira, and today I'm here at the Mayo Clinic with Dr. Emmanuel Gabriel, a surgeon-scientist who specializes in cancer. Dr. Emmanuel, you have an incredible story about why you ventured into medicine. So tell us about it. What were your pre-medical years like, from childhood to undergrad?
Yeah, actually, when I was a kid, I wanted to play for the Yankees, but that didn't work out. So, yeah, they got Aaron Judge instead, and I'm stuck doing this. But I then eventually wanted to do law. I actually thought I was going to do political science and law. In high school, I became not as good with the sports, and so went into things like debate and model Congress and stuff. Really helped my public speaking, and I thought that's where I was going to go. And I went to Drew University. It's a small undergraduate school up in New Jersey. Probably the most famous person you may know is Dawson from Dawson's Creek. You may be too young, but he would have been a senior when I was a freshman, but he became famous. It's a very good school for politics. My freshman year, my mom got sick. She got breast cancer. And so that switched everything from my interest in politics and law going into medicine. That's where that switch came about.
Okay, so what caused you to specialize in breast cancer of all cancers?
Well, my mom had breast cancer. I actually I do kind of 50% breast cancer and 50% other surgical oncology. And at the time when I was in college, this was 1999, and so I wasn't really able to counsel my parents. I was still a college student, didn't know anything. The science and the treatment was pretty different, even though 20 years ago, not that far, it was pretty different. And just watching what she went through, it was difficult. And so I felt kind of like this is a calling to try to help people like her to she had a very good outcome from the surgery, to try to help others like her, and to try to make treatments better, to try to help patients not suffer as much through certain types of treatments.
Yeah, so why is cancer research so important? I mean, holistically speaking, for the people who may not know what cancer is, why is cancer as a disease so disastrous?
It depends on the type of cancer, and it depends on the stage when you're diagnosed. But even despite all the advances we've made, there are still a pretty substantial number of patients who don't benefit from current treatments. Mm-hmm. And so either they're resistant to them, or they just don't have the biology of the tumor to respond to what we're able to offer them, and that can be very devastating to patients. It really comes down to the genetics. We don't know all the answers, but for melanoma, for example, I'll give you an example. Back in 2011, they came out with immunotherapy, the first immunotherapy drugs. Actually, one of the graduate students in the lab before me worked with Jim Allison, he's now at MD Anderson, but at the time they were part of Bristol Myers Squibb, and did the first trials for a drug called ipilimumab. And that revolutionized treatment for metastatic melanoma because the survival for metastatic melanoma was less than 5% at 5 years. And that increased it to around 30 to 40%. Now with other drugs, it's as high as 50 to 55%, but then there's still that 45 to 50% that don't benefit or don't have long-term benefit. Many groups have studied this, showing that they become resistant to the drugs we can offer.
You've had really great mentors throughout your career. Tell me about your mentorship you received from the Nobel laureate, Dr. William Campbell.
Yeah, I got lucky. Drew University is a very small school, but they do have a program where they employ previous scientists in industry. Mm-hmm. And he worked for Merck for a long time, in the 60s and 70s. And he developed a drug called ivermectin, which is used to treat. Well, the original purpose was to treat parasites in your food sources, like cows.
Yeah.
But it also, they found, would treat parasitic infections in humans. Particularly in Africa, there's a worm called onchocerciasis. It causes river blindness. And they found out that this drug also worked for these patients. So because the drug was pretty inexpensive, together with a philanthropist named Roy Vagelos, Merck and the company decided to give the drug pretty much for free to treat that that illness. But he's phenomenal. I mean, he didn't win the Nobel Prize until 2015. Mm-hmm. So it had been maybe almost 15 years since I graduated, 12, 15 years, something like that. But very humble, very nice, still alive. I try to invite him down here, but his health is, I guess, not as good. He's more frail these days, I guess. But he was just a very humble person, taught me about the basics of the scientific method. I wrote my first, or actually he helped me write the first paper. He basically, wrote it for me, and then I kind of reviewed it and stuff like that. But my first paper was with him, and that's really where I got my inspiration to do research, to try to, like I said, help patients have easier ways to go through treatment.
What are the most important things that you gained from, both personally and professionally, from the mentorship of Dr. Campbell?
I would say the humility. This is someone who won the Nobel Prize, and if you watch his speech, so you can watch it on YouTube, it's very funny. It's very funny when he talks about worms in front of, the Nobel Prize royalty and all the folks who do that award, and all the princes and kings and people who go to that award ceremony. So he's very humble. He taught me that failure in research is super common. I failed so many times with experiments, and it's extremely discouraging. But he showed me that, it can still be fun and rewarding if you stick with it, and eventually, even out of those negative results, you still can get valuable information. So, it's very rare for someone to have results, experiments that are all successful in a row. I would say probably less than 10% of my experiments have been successful and lead to a meaningful publication in science.
So over the years, you have become an expert in really complex surgical oncology procedures. And I know you mentioned CRS HIPEC and isolated limb perfusions and infusions.
Mm-hmm.
So for the people out there who may not know what that is, could you kind of give a simple explanation of what that really is?
Yeah. So so CRS stands for cytoreductive surgery. It's kind of like a debulking surgery, trying to remove as much as tumor as possible that you can see. It's typically within the abdominal cavity. So like this room, if you think of this room as the abdominal cavity, like we and the furniture are the organs, but there's also a wallpaper, just like the wall here. This isn't wallpaper, it's wood, but like on other walls there's wallpaper. There's a lining like that in our body. And the tumors can grow on that and kind of creep along the wall and just kind of spread. So we try to remove the wallpaper, remove organs that are involved, and then circulate chemotherapy, heated chemotherapy, into the abdominal cavity for about 90 minutes to try to get rid of any microscopic disease. This is something I really learned in fellowship, not so much in general surgery. It's something that's kind of a step after general surgery in a subspecialty. The other regional therapy you mentioned is a limb perfusion. So in an arm or a leg, it's kind of the same principle, where patients get a lot of disease kind of crawling up the arm or leg, usually from a melanoma or some other type of skin cancer. Very hard to treat because you can't just kind of like remove all of it. You would leave large defects in their skin, can't close the wounds. So we put catheters. Actually, my colleagues in either radiology or vascular surgery will put these catheters in for me, and then we'll be able to circulate that chemotherapy through the arm and keep it away from the rest of the body.
And what exactly are catheters?
Catheters are these little tubes, kind of like an IV catheter, but the gauge of the tube are much thicker, so they can accommodate a high flow of pressure.
What would you say is the future of oncology? Is there a cure for cancer just around the corner?
I hope so. It's a very loaded question. I think there have been many strides for specific cancers, particularly with immunotherapy. Melanoma, kidney cancer, lung cancer, immunotherapy is very useful for those. More and more research is trying to see if they can be applied to other types of cancers. There are new types of drugs that connect chemotherapies to antibodies. They're called antibody-drug conjugates, and they really help deliver the chemotherapy to the target. And that's something that I think I'm very hopeful for, to try to limit the chemotherapy, the sort of traditional chemotherapy that kind of just attacks everything that's dividing. That's where really a lot of the side effects come in. There's a lot that's being done around the world and here at Mayo Clinic on cancer vaccines to try to prevent getting cancer by trying to expose the body, the immune system, to different cancer antigens. That's something that I work on with my research. And other things that I try to work on is to improve drug delivery. So I try to alter the tumor blood vessels to try to increase the blood flow at the time of drug delivery, and also try to create sustained release formulations. We call them nanoparticles or liposomal nanoparticles, which are small versions of basically like fatty capsules that hold the chemotherapy inside, and then as they break down in your body, they slowly release the drug at the site of the tumor. So there's a lot going on. There's so much going on.
Should mac and cheese be eaten with a spoon or a fork?
I think both. I think you could choose. You can use a spork if you want. I'm not sure how that question came in, but yeah, either one's fine. I usually use a spoon.
Okay. Tell me about the process of becoming an MD, Ph.D., and what are the pros and the cons of becoming a physician scientist? Because, I mean, you think about it, right? So, I mean, you have your PhDs who dedicate their entire life to being a scientist.
Right.
And then you also have the MDs who dedicate their whole life to being, the physicians. Right. So how do you find that balance, or is there a balance between, managing this, the scientist and the physician aspect to your career?
The balance is very challenging. I'm fortunate that I found a job, and Mayo's been very supportive in that I can tailor I can integrate my research with my patient population. So I do some clinical trials in tumor vessel imaging, which is directly related to the blood flow manipulation and imaging that I do in mice, for example. So one of the pros is, and it's not for everybody. I mean, I think, I have partners who love taking care of patients every day, day in, day out. They, have clinic twice a week. They operate 3 days a week. And then like you said, the research scientist is, focused on their lab work, their team, they're writing grants pretty much all the time. It's very challenging. And so I don't do both of those 100% each, but I try to make it easier on myself by integrating the two aspects of that life. So if I have patients with the same diseases that I study in the lab, then I can use their tissue in the lab. We can send them to harvest, to save some of their tissue after the tumor resection, and to test out different imaging modalities both ways. The cons are really the time. So I can tell you, from college to the time I got my first job was 19 years. And I know folks who took longer than that. So I did, if you count college, it's 4 years of undergrad. I did 4 years of medical school, 3 years of graduate school, so that we're at 11 now. 5 years of general surgery residency, and some people take off time to do more research. I was able to go straight through residency. 2 years of fellowship, and then 1 year of postdoc.
Oh, wow.
So yeah, so that I would say is one of the cons. It does take a long time, and so you're in your mid-30s to early 40s by the time you have a quote-unquote real job. I mean, it is a job while you're a resident and doing all the things, and you are getting a salary, although it's very low for the hours that you're working. But in the end, it's very worth it. But it is very challenging. I'm not yet an established independent investigator. I'm trying to get that level of NIH funding now. I do have what's called a training award, or a K award, specifically a KL2 award. And so I'm in the process of trying to get to the next step. So by the time, if I'm successful, hopefully I am, by the time I get to the independent stage, which is what we call an NIH R award, that would have been, 25 to 6 years. Oh, wow. Yeah.
What is one moment when you realized you made the right career choice? I mean, even through all this.
Yeah, so I would say during the whole process, it's important to have your life outside of the career. So my parents' life, my family, I have children, all of those folks are supportive. I would say probably when I got my K award, it made sense to me that I was on the right. That was in 2019. It sort of made sense, or sort of validated, I guess, my career choice, because that is the step of a surgeon or a physician scientist or surgeon scientist, is to get that funding. It's NIH related funding. So once I got that, it kind of felt, oh yeah, I did the right thing. I took the time to do the postdoc. I took the time to do the PhD. It made me more competitive to get this training grant, and now publishing papers off of the training grant to hopefully get to the next stage.
Describe the most exciting moment in your research experience thus far.
It's probably the stuff that I'm doing with the K, and transitioning into the R. So we have very interesting data that shows that we can alter drug delivery through different ways. And there's kind of simple ways, like giving extra fluids, giving what's called vasoconstrictors or vasodilators to alter the way the blood flow goes to the tumor. And if we time that well, if we deliver a drug at the same time, we can increase the drug concentration into the tumor cells. So this is pretty cool, I think, to try to limit the toxicity in patients. We did a trial where we looked at the tumors of those folks who have like in-transit disease, or who need the regional therapies, and you can see that some of the blood vessels don't support blood flow. We're trying to change that to increase the drug delivery.
When I was younger and I asked my grandfather, what it really took, what I had to do to get a Ph.D., he told me that I had to discover something and be the first one to discover it. Right. So what was your Ph.D. proposal and what did you research or discover?
Yeah. So I worked during the time of what's called CTLA-4 or T regulatory cells. That's been pretty much all worked out with Jim Allison and ipilimumab and others, of course. But what I was trying to do was combine that immunotherapy with a vaccine that increased expression of a tumor antigen. So I'm kind of doing the same thing now. So we use viruses. Back then it was a thing called the vaccinia virus. Now I'm using a thing called the lentivirus. And you can insert different genes into these viruses, then they infect cells, and they express a tumor antigen or a tumor target. You combine that with the immunotherapy, and you get results. So that was kind of, I'm not sure it was super novel at that time, but it was a bladder cancer model, and leading to the same type of thing, publications and things like that. That was my PhD, essentially my PhD. So my PhD is in cancer immunology.
What's it take to be Dr. Emmanuel Gabriel?
I don't know, really. I think just a lot of patience. The job can be difficult. Sometimes, patients have bad outcomes. They have complications. Sometimes they can't be avoided. Sometimes they can. And it gets me really down, when those things happen, because I try to, I see patients like my mom. I kind of see them as I'm treating them. I see her as I'm treating them. And so I think of my own family members who have had bad outcomes. I really try to prevent that as much as possible, but they still happen, and at the same time, you're trying to run the lab, you're trying to write the grants. Like I said, there's a lot of discouragement with grants. Again, probably I have an 8% success rate in getting funding. I don't know anyone, even my mentors from the K Award, no one's perfect. They don't get the funding the first time. That's very unlikely to happen. I'm sure there's folks that are out there that are like that. But it takes a lot of, resilience and just kind of enjoying life while you're going through that process. That's probably what's helped me stay successful. Just trying not to be so depressed when there's an issue with a patient or when you don't get funded for a grant, things like that.
So would you say that's the most challenging part of your job?
That's probably the most challenging, yeah. The balance is something that you can work out, and you do need an institution that supports that endeavor. So I do, on paper, I'm 50% research, I'm 50% clinical. The grant has protection for 50%. In reality, sometimes the clinical aspect encroaches into the research, because if there's a sick patient or a patient who needs to be seen sooner, certainly I have to accommodate those patients because they almost all have cancer, and then I have to make up the time on the back end. But I've gotten pretty good at sort of balancing those things. It's really more so, dealing with disappointment from the funding standpoint, or if a paper gets rejected. That's also very common, unfortunately, and then you have to try again, take the reviewer comments, the feedback, resubmit, and then balance that with the clinical practice. But Mayo Clinic has been very, very supportive of that balance.
What would you say is the most valuable achievement as a physician scientist so far?
It would have to be the K Award again, the KL2. I think that's a big step up when you're able to get NIH funding. It sort of, kind of validates what you're doing, because it undergoes kind of a very rigorous peer review system, and then it really sets you up with the protected time and the mentorship to go to that next step. If I didn't get that in 2019, I might not have protected time right now. I might be, strictly clinical.
Right.
So I would say that's probably the biggest kind of achievement milestone.
Do you have any advice for the younger generation of scientists who may or may not be thinking of an MD, PhD, or pursuing one?
I think definitely talk to physician scientists out there. They're, compared to PhD scientists, there aren't too many, relatively speaking. But they're definitely out there in all specialties. I'd say there's probably fewer in surgery. But we have some, I think I mentioned Dr. Q is here, neurosurgeon, wonderful, humble guy, just like, Dr. Campbell, who won the Nobel Prize, very approachable. But I would say, know that the road is long. There's no real shortcuts. I did the PhD in 3 years. Most people would criticize that and say, well, it's not a true PhD. My wife did a PhD in 6 years in environmental sciences, and there are others who did it in 5 or 6 years. But there's ways in the MD PhD program that they get around that with the coursework and stuff like that. But it is still a very long road, particularly if you want to do any type of surgical subspecialty, because most surgical subspecialties will be 5 years. But if you're able to be successful and find that support, find the mentors, find the institutions that will support you, then your lifestyle can be very nice, because you get to take care of patients. You get to treat people that you want to treat, that you may have had. Cancer is very common, unfortunately, so a lot of the folks I know who are oncologists derive the same inspiration from their own family members who died or were treated for cancer. But at the same time, you can leave that realm for a while and then do stuff that is a little less sort of programmatic. The treatment algorithms are kind of pretty much standard. There's a couple of patients who get more complex where you have to be a little bit innovative in how to treat them, but for the most part, you follow the guidelines. And then doing research is more, there's really no, there's certain standards in, rigor and ethics, but there's no, you don't know what to do. It's more open and more imaginative. So I would say, definitely talk to other folks about their timelines and try to have your family support during the time, because without that, I think it'd be very difficult, at least for me, without that support, that support system around you.